Okay, a prescription. So prescriptions order for medication issued by a doctor or licensed healthcare prescriber. So something that I even have to remind myself constantly is to use the word prescriber or practitioner, because for years it was only doctors, dentists, whoever it was. They had a title as doctor. But then we have physician assistants, and we have nurse practitioners, pharmacists, optometrists. So there's uh, just like uh, we don't always want to use the word him or her because there's both sexes. Well, it's the same thing. You don't always want to say physician because that might be offensive to somebody who's not a physician. They're a practitioner. So somebody who's able to prescribe, a licensed healthcare prescriber for a valid medical condition. So something I'll just point out, I'm a certified diabetes educator and board certified in advanced diabetes management. I have prescriptive authority. I'm licensed in Texas. I'm licensed in New Mexico. In Texas, pharmacists are not allowed to write controlled drug prescriptions. We are in New Mexico. In New Mexico, we can write Schedule 2, um, which is why I like being licensed in New Mexico. I think that pharmacists should be able to write prescriptions as long as other people are being allowed because we have the education and the training. Now in Texas, I have prescriptive authority. However, I can really only write prescriptions related to treatment of somebody with diabetes. It can be completely diabetes related, or it can be anything medical, but with a diabetic patient. So if I had somebody that's a diabetic patient, let's say that she just got type 2 diabetes, but she develops a rash somewhere on a part of her body, and she's tried a couple of things. She just needs a stronger topical steroid. I can prescribe that. So, but if I was to prescribe something, let's say, um, well, just as a favor for somebody, and it was really outside of the scope of what I'm authorized to do, then I'd be breaking the law. So types of prescriptions. We have written. That's the most common. So that's whenever you see somebody brings in a piece of paper and hands it to you at the community pharmacy. Faxed. Faxes, they still exist, but they're not the big deal. There was a time when faxing was just a sensation. I mean, there were commercials on TV where somebody could send a fax and somebody in a car could receive the fax. And everybody was just, oh, they couldn't believe this. This is before like cellular phones and all. But faxing used to be the most convenient way to get something from point A to point B. Whereas now, you can literally email, you can take photograph and send. So it's not nearly what it was, but there was a time when it was a big deal. Telephone and electronic. Electronic is just or internet, but it's e-scribe or e-scribed. In the past, it was just doctors, and by doctor, so a DO is a doctor of osteopathy. They only go to college for about 5 years, but they're still a doctor. MD is a medical doctor. They go to school for 6 to 8 years. DDS is a dentist. A DPM, they go to school for 4 to 5 years, but they're a doctor. So all these different professionals had the title doctor. And in the past, it was just doctors who wrote prescriptions. Today, there's multiple practitioners with prescriptive authority. So the correct word is to use practitioner or prescriber. And just like I said, I'm constantly having to remind myself of that. Types of written prescriptions. So they're written by the prescriber on a pre-printed blank. Written prescriptions can be scribbled, by the way, on a scrap of paper as long as they contain all the legally required information. When I worked at Target, they always had this coupon where you would get a $25 gift card if you brought in a new prescription. Every single time they ran that ad, there was a woman, she had 6 children. She'd come in, she'd ask for a piece of paper. She would tear it into 6 pieces. She'd scribble her name, address, phone number, and at the top of her practice. Then she'd write down each one of her children's names. She'd write them all a prescription for either Tylenol or ibuprofen, and then sign it. And the fact of the matter is, it was a legally acceptable written prescription. She was a physician, and she knew she was going to pay $2 or $3 for her ibuprofen and get a $25 gift card for each of them. But so you don't have to have a formally printed with information. Hold on. Well, if anybody can text Maribel, that's her. But I'm going to record this so she'll have to just see it. So any designated agent is allowed to write and complete every aspect of a prescription. However, the prescriber must sign it. And this might seem trivial, but you're going to find even in pharmacy, it's not a matter of being lazy. It's really a matter of delegating and using time. But for a doctor, for example, if you were my assistant and I saw a patient and there were 3 things I wanted to prescribe, I could tell you, I could say, okay, I want to give them, let's say, prednisone 10 milligram, 1 daily for 5 days, and then a half a tablet daily for 5 days, and then discontinue. So and then just calculate the quantity. And I want to give them some Orapred, and then I want to give them some hydrocortisone, change that no beclomethasone, and then I'll sign the blank and give it to you. And you work with me long enough, you know, oh my gosh, he just said a whole bunch of things, but I know exactly what he meant. This is what he wants. And you could write it all out and give it to the patient and it'd be done. So the doctors, it's real common for a doctor to pre-sign a blank, or even there's instances where a medical assistant or a doctor's assistant goes in, takes a patient history, and the physician, before the physician even comes into the room to see a patient, the physician's going to look at the summary of why is the patient there, and then their vitals and information, and pretty much decide what they want to prescribe. And so it's very common they'll tell one of their coworkers, this is what I want. And it's so routine, as a matter of fact. Some conditions are just so common, like a young child with a certain strep throat and runny nose or an ear infection. They're going to get these like 3 or 4 of the same prescription. The nurse knows it, so the doctor will just sign a prescription and tell them this is what I want. But anyhow, anybody the doctor designates can fill out everything except for the one thing nobody can do is the doctor's signature. It's very common for doctors to sign multiple blank prescription forms. Now, one practice, and it's unethical, it's illegal. Doctors are allowed to supervise up to 8 nurse practitioners. Nurse practitioners, they're nurses that have advanced certification degrees, and they are able to write prescriptions, but they do so under the authority or supervision of a physician. And what happens, though, is they cannot write Schedule II prescriptions, but doctors get greedy and they want to have 5 or 6 different clinics open. And so when patients come in, let's say a patient comes in to see the doctor, they want a Schedule II prescription. Well, the doctor's not there and can't provide it. But if the doctor signs some forms and just left blank forms, then his nurse practitioner can complete it and give to the patient. So that's really a dangerous and legal, potentially illegal habit. So it's dangerous. Now, this is the most important take from all of what I talked about. A written prescription requires the signature of the practitioner to be valid, period. A stamped prescription might look like it was signed, but a stamped prescription is not valid. I wish I could learn how to turn that off. And by the way, I was working when I was at Pima. I had this horrible, it was an abscess in my tooth, this horrible pain. Went to the doctor, he gives me antibiotics and pain medicines, but whenever I'm leaving, the way he did it, his secretary just pushes a button and the computer, it prints up all the prescriptions and printed everything in it, prints it out, and then it had the line where the doctor's supposed to sign. And then, and so I noticed he did one of them. They actually gave me a prescription for like 10 Norco, and the doctor signed that one. But then there was a prescription for Amoxil and for Ultram. And the nurse got out a rubber stamp and she stamped them. And I said, first of all, I said, like, okay, he came over here, he signs one. Why didn't he just sign all three while he's at it? And she goes, oh, he's too busy. Okay. And then I said, well, you know that's not legal. And she goes, we've been practicing 25 years and not a single pharmacist has ever had a problem or call. So anyhow, I'm going to go ahead and go home, and we're just going to get the medicines filled nearby. Well, my older brother, he's a regional manager at Walgreens, and he just happened to be in Houston for a convention, and he was visiting a pharmacy that was in Pasadena. So I thought, oh, you know, I'm going to stop by there. I'm going to get it filled so I could visit with my brother because he was going to be flying back that night. So anyway, I get to the pharmacy, I turn it in, and me and my brother, we were visiting, having a great time. After about 45 minutes, I went to get my prescriptions. And then, of all things, my older brother, he's like, we can't fill this. This is a stamped prescription. And I told him, I said, don't you think I noticed that? And I said, you know they're legitimate. We had to call the doctor's office, the dentist. They were closed. So I had to over that. So legally, no, it's got to be signed. A stamp doesn't work. Fax prescriptions. So this is a prescription that would be written and faxed to the pharmacy. And in the past, what they would do, a doctor would write a prescription and then fax to the pharmacy. Now, this is a dangerous habit because let's say if you have an employee that works for a doctor's office that's wanting to divert drugs, before things were all connected with all the technology we have, well, they could fax a prescription into 15 different pharmacies and not a single one of them would know that they're filling medicine for the same patient. So when something short of having an authentic original in your hand opens up the door for some problems. We have e-scribing, it's replaced faxing. Now, where you will see faxing is Schedule II drugs. A lot of times, let's say that somebody's got cancer or severe pain. When they're sometimes the Schedule II prescriptions are written in situations where somebody's in extreme pain and it's an emergency situation. So even the matter of time till they can get the medicine filled is important. It's very common for a doctor's office to call a pharmacy to fax a Schedule II drug so the pharmacy can will receive the fax. We know that the patient's going to be bringing us the original. And with a Schedule II, you have to have this unique number anyhow, which would be in the fax. But if they fax it, it's only so we can get started on it and have it ready. So when they come in, they give us the original. But you can't ever accept a faxed C2, fill it from that without getting the original. Telephone is just what it is, called into a pharmacy. Once again, a practitioner can designate any agent to call. So it can be the receptionist. Anyone that the doctor feels comfortable, trustworthy, can be designated to call in prescriptions. By the way, though, telephone prescriptions account for over 30% of prescription misfills or errors. Then we have the e-prescription, transmitted electronically from the doctor's office to the pharmacy, and they use a computer or a tablet. Or they even have or even your iPhone. These are the three different. Remember, I mentioned. So Schedule I, they cannot be filled. They're not a prescription. So we have non-controlled prescriptions. They are addicting. There's no potential for abuse. Then we have controlled. Of the controlled, we have C2 and we have C3 through 5. So C2, they have the highest potential for abuse and addiction. C3 through 5, as it gets closer to 5, it's less and less likely to be addictive or abused. Now, this is just a comparison. The type of prescription here, non-controlled, C3 through 5, C2. The form, how is it transmitted or what form must it be presented in? So you're going to notice all of these can be provided in written form. A non-controlled in C3 through 5, they can be telephoned in. They can send, I mean, they can be faxed and they can be telephoned in. All three of these can be sent electronically. And then I put the telephone here or fax. This is an emergency only. It's just an exception, and just you don't need to memorize this. Just have a vague recollection. But with Schedule 2 drugs, if there's an emergency, a legitimate emergency, a doctor is allowed to call in up to a 72-hour supply, but then the doctor has a legal obligation to submit an original copy, mail an original copy to the pharmacy within 48 hours. But something that's real important to remember that's changed now with Schedule 2 drugs, even to fill a Schedule 2 prescription, you have to have a unique number. Every single prescription written for a Schedule 2 drug is going to have its own unique number. So if a doctor does telephone in an emergency prescription, he's still going to have to provide the pharmacist with a 10-digit number. So he's going to be reading it off the original that he's going to be mailing in. It's very, very, very rare. Now, what is this valid? Valid is how long is the prescription good? So if it's non-controlled drug, it's good from 1 year from the date that it's written. And remember that, that's something to remember, because it's very common for somebody to receive a prescription, put it in their billfold, wait a couple of weeks, couple of months, they just might not need it, might not think they need it, then bring it in to have it filled. And so when you're typing it in the pharmacy, by default, the computer automatically puts that day as the day it was written. You need to always make sure that you enter the date a prescription was written, if it wasn't written that day. Just so you know, also, sometimes doctors just forget to date a prescription. Technically, it's not valid. If it's not dated, it's not valid. But otherwise, just you use your good judgment or do what the pharmacist recommends. For Schedule C3 through 5, it's good for 6 months from the date that it's written. And then with a Schedule 2, and I'm going to show you the Schedule 2. So depending on the state, in Texas, from the date it's written, a Schedule 2 is only good for 21 days. But I don't want you to get confused by that. If you're tested on the PTCE, they don't test based on state because it's different in each state. But one thing that's federal that does apply to all states, there's a maximum day supply that you can write for on a Schedule 2 prescription. So the most that a doctor can write for on a Schedule 2 prescription is 30 days worth of medicine. And so we're going to talk about it in just a second, but next here is refills. How many refills can the doctor give a prescription? If it's non-controlled, there's no limit. So a doctor may not give any refills. If there's no number designated, then it's 0 refill. But a doctor can give 0, or a doctor can write PRN, which would mean a patient can fill as many times as they want for that whole year. So the prescription is good for a year from the date written, and it can have up to unlimited refills. Sometimes it's got no refills, but it can have up to PRN. And then transfer. Transfer just means when you're taking your medicine, you fill it at one pharmacy, and then the next time you fill it, you go to a different pharmacy. So that would be a transfer. With non-controlled drugs, you can transfer as often as you want. So let's say that it's birth control. It's real common for women to have birth control, and they might go shopping and they're at Target one day and they think, I'm going to be here for an hour or two, so I'm just going to go ahead and have it filled here today. And then the next time they're at Kroger's and they're going to be shopping for groceries, say, hey, I'm just going to fill it here today while I'm waiting. And especially if you have insurance and you pay the same amount, no matter where you go, there's no reason not to. Now, a controlled 3 through 5, it's only good for 6 months from the date written. There's a maximum of 5 refills, so doctor cannot give it any more than 5 refills. And then it can only be transferred one time. So if I filled it the first time at Walgreens And then the next time I go to Cujo's Pharmacy. If there's refills left on it, I have to get them at Cujo's. Once you transfer it, it's no longer at that first pharmacy, and you can't transfer it again. Now there's an asterisk, which is an exception. If you fill it at a pharmacy that has a shared database, then they don't count it as a transfer. So Walgreens, CVS, Target, Walmart, any of those chains, any pharmacy that has more than one pharmacy, if they have a connected database, then you can fill it at any one of their pharmacies. It does not count as a transfer. So if I had, let's say I had Xanax and I filled it in Hawaii, and then a month later I wanted to fill it in Texas. A month later I was in Alaska. A month later I was on Mars, and there's a CVS on Mars. I could transfer it. So as long as they're connected, then it doesn't matter, but otherwise it's one transfer. With Schedule II drugs, the most a doctor can write for at one time is 30 days. No refills, no transfers. Something else, I don't want to confuse you, but with Schedule II, if you ever hear of a partial fill, let's say a doctor writes a prescription for a pain medicine and writes for 100 tablets, but it's extremely expensive, and a person's very sensitive to some medicines and is reluctant to just spend all that money in case they can't take them all. If the patient says, you know what, I just want to get 5 tablets, and then if I can take it, I'd like the balance. Well, you can't do that with a Schedule II drug. With a Schedule II drug, you can ask for the pharmacy to fill less than what the doctor ordered, but if you do that, then that's all you get. You just get that partial fill. On the other hand, if the pharmacy doesn't have the full amount to dispense, they can partially dispense what they do have, and they have 48 hours to get the balance and fill it. You're going to see tamper-resistant prescription pads. There's an agency or an organization called CMS, the Centers for Medicare and Medicaid Services, and they represent who? People that are on Medicaid. They represent people that are on Medicare. They implemented it's a regulatory action. It's not a law. However, they control reimbursement for any healthcare treatment. Any prescription written for a Medicaid patient has to be issued on a tamper-resistant prescription pad. And so these are fancier, they're a little more expensive, but they have features. Like it might look just like a light blue prescription, but if you try Xeroxing it, the word void will appear. Or there are various features that'll show up under a black light. Or in Texas, we have on our Schedule II, there's a tiny square. If you rub it, the prescription, it'll make a little pink check mark. So these are pads that are invented so that they cannot just be scanned and reduplicated. So the C3 through 5 can be e-prescribed, written, faxed, or phoned in. Schedule II must be written. There's a few exceptions, but I'm going to show you an example of a Schedule II. Each blank, they have a unique ID number. So exceptions would be that I mentioned earlier, the telephone and emergency supply, which is no more than 78 hours. Then the doctor has to mail the original to the pharmacy within 48 hours. But it's not a big deal as much as it used to be, because the only way you can fill a C2 is if you have that unique prescription number from the prescription blank. If a doctor has to give you an emergency supply, he's going to have a blank in front of him and provide that number to you. So we used to dealing with fraudulent prescriptions used to be a whole lot bigger of an issue, and now it's no longer the same. They can be transmitted electronically. And so what happens to submit electronic prescriptions, you do have to go through several security steps. You have to make sure that the account that's being created is for the person creating the account. So the doctor who's going to be writing these prescriptions, any of his agents that are authorized to submit prescriptions through the system. The same thing with the pharmacy. The pharmacy has to have set up so that it has been verified. The transmissions they're receiving from this person, it is this physician, and it's authorized. So initially, it takes a couple of days to get set up. Once it's set up, then you have it, and so now just about every doctor, now it was supposed to be by 2011. Originally, by 2011, all prescriptions were supposed to be required to be transmitted electronically. The problem is, to transmit them electronically, both the pharmacy and the doctor have to have special software, and the software is not cheap. The minimum cost for the software for a physician, if they have to sign a $50,000 lease or contract where they're paying $5,000 a year for 10 years. So if they want to retire in 2 years, they're still stuck. They're going to be paying $50,000. So the cheapest that you can even obtain the ability to have e-prescribing privileges is $50,000. Now, if you're a doctor working at a practice with several practitioners, that's not a big deal. It's just divided among everybody. But if it's a single doctor or an elderly doctor or a doctor who's planning to retire, then that's a huge investment. They don't want to have to invest the money. Because of that, it was originally supposed to be implemented nationwide in 2011, and it just keeps getting pushed back and then allowing exceptions. But just think about it, if there was a dentist and he's a single practitioner, and he's planning on retiring in 1 or 2 years, is it reasonable to force him to have electronic transmission? So who can write prescriptions for controlled substances? Mid-level practitioners, they cannot write Schedule II prescriptions. There's only one exception, and the only exception is if a person's in a hospital and they're being transferred to hospice care. A nurse practitioner can, only representing a doctor, issue a 2-day supply of a Schedule II. So in fact, what they're doing, they're just acting on the doctor's behalf. So for all practical purposes, only a physician can issue a Schedule II prescription. One of the reasons is they made hydrocodone a Schedule II was because after nurse practitioners, they started granting nurse practitioners authority to write prescriptions. Nurse practitioners started opening clinics all over the nation. And they weren't just opening clinics, they were opening clinics that specialized in pain treatment. And they were seeing patients and writing prescriptions for diet pills and pain pills. And it just got out of hand and was part of the reason we have an opioid epidemic. So by making hydrocodone a Schedule II, it shut down these clinics and significantly decreased how many prescriptions were being made available each day. A doctor's DEA number is required for any controlled prescription. Now, this is extremely important. If it's a controlled drug, the quantity has to be written numerically and alphabetically. That's to prevent diversion. So if a doctor wrote number 10, you might have to hunt around, but you'll find a pen that's a similar enough color ink. You add a 0, and all of a sudden you get 100. Or change that 1 to a 4, and you get 40. So by having to write it numerically and alphabetically, that's just to help prevent any kind of fraud or diversion through changing the quantity. So who needs a DEA number? Any practitioner that prescribes or distributes, receives, dispenses controlled substances. So that's our wholesaler. So the wholesaler is going to have a DEA number. A pharmacy, for pharmacies to be able to receive and dispense controlled drugs, they're going to have a DEA number. And then the practitioner. We've gone over this before. We'll go over it in class. I don't want to get tied up wasting time on this, but I'll go through it quickly. There's 2 letters and 7 digits. There is an exception. So remember this, there's one exception. Suboxone, and if you notice that X right there, Suboxone is 3 letters and 7 digits. Suboxone is a drug that was originally approved for people. It was approved to be used on a daily maintenance basis to help people who were addicted to crystal methamphetamine. Now it's used for everything from heroin to hydrocodone, alcohol. But With the Suboxone, the doctor is going to have an X and then 2 letters and 7 digits. So a DEA number, what do we do? If the DEA number would normally be this right here, which is 2 letters and 7 digits, if the doctor has a Suboxone clinic, so that means, and the way it works with the Suboxone clinic, the doctors usually have a pharmacy inside their office, and patients will come in every morning at a certain time. They'll get their day's worth of Suboxone strips. How do you verify the DEA number? So the very first letter, if it's a doctor, remember doctors are fabulous, it's FARB. Mid-level practitioner, M. Second letter, it's the first initial of the last name at the time the DEA was issued. So just keep in mind for females, I guess even males, if you get divorced or if you get married and the name changes, so that second initial, if it's different, don't automatically assume that there's something wrong. It usually is just divorce or married, just a name change. How do you verify the DEA of the 7 digits? So you add digit number 1, 3, and 5. Then you add digit number 2, 4, 6, and multiply times 2. You're going to add X and Y, and then that 7th digit is going to be your last digit of the DEA. So to come check this one, we've got our first, third, and fifth is 2, 9, and 7, you get 18. Then if we get our second, fourth, and sixth, it's 1, 3, 5 times 2, 18. 18 plus 18 is 36. The last digit's a 6. Once again, the quantity on controlled substances must be written numerically and alphabetically. Here's another rule I mentioned, just if it's not specified, then there's 0 refills. It's actually a best practice for a doctor to write no refill, NR, something, because if he leaves it blank, guess what? A patient can put times 3 refills or something. So it's always best if a doctor will designate. If it's a 0, he can write NR. Okay, components of a prescription. With the prescription, you need the patient's information. Now, you're going to find when you work in a pharmacy, what is legally required on the doctor's end? Well, they have to put the full name of the patient. They're supposed to put the address, but a lot of times they leave that blank. So you're gonna fill it in on your end. Age, that's not a requirement, but when you're working in a pharmacy as a standard of practice, you want to use what they call 2 different patient identifiers. And one is birth date. So when you're given somebody's birthday, that's a unique number. Out of our entire classroom, it's very unlikely that any of us have the very same date for a birthday. And so that really is a unique identifier for a patient. Then you've got your name, so that's an identifier. Even your address and telephone number, but the very best are your name and your birthday. You're going to notice on C2 forms, it has a place where the doctor can use either birth date or can list the age, either one. Prescriber information. Now, this is required on a prescription. Some of it's required, some of it's not. This came out of the book. What is required on the prescription that you're filling? So even if a doctor just picked up a blank piece of paper and scribbled it out, you have to have their name. You have to have their physical address of where they're practicing. You have to have a number where you can reach them. Now, a DEA number is only necessary if it's a controlled drug. If it's not a controlled drug, it does not have to be there. NPI number. It's very simple now. There's a national database. So if you're filling a prescription, and you don't have an NPI number, all you do is type the name of the doctor in, and you'll find out the NPI. It's an 11-digit number, and doctors have it, pharmacists have it. the soon enough technicians will be having it. But the NPI number, if I perform a service, if I do a DUR, or if I go do a review of a nursing home patient, when I'm filling out a bill, they don't want to see my name, address, and a bunch of information. They just need my NPI number, my National Provider ID. That tells them that I have got all the credentials, that I've been approved, all the information that's needed to get in touch with me or whatever. It's all accessible through this national government database. And here's one single number that is mine, my unique number. So a lot of prescriptions have it pre-printed. That's not required yet, but the signature of the prescriber, that is. So having this right here, the doctor's name and address, having the telephone and signature, those are required elements. DEA is only required if it's controlled. And in this example, I used alprazolam, which is controlled. It's a Schedule 4, which is why I put the quantity and included the DEA. So here we go. Medication information. What is the inscription? The inscription is your medication prescribed, the strength, and the quantity. So inscription here, Coreg 25 milligram tablet, number 60. That's the inscription. Now there's two prescriptions on here. The second one, hydrochlorothiazide 25 milligram tablet, number 30. So inscription is the medicine, the strength, and the quantity. And it's always put in that order. So you put the name of the drug. If it's a sustained release or extended release, that'll come next. So if there was a Coreg SR, then I'd have Coreg SR, then the strength. So you have the name of the drug. If it happens to be a sustained release, that comes next, but then the strength and the dosage form and quantity. The Cigna, so y'all are familiar with SIG codes. The Cigna, that's directions for how it's to be used. And so here's SIG codes and SIG codes. You'll see a lot of just the abbreviations. A subscription, that's what we call the subscription. That's your dispensing instructions to the pharmacist. So let's say that it's a compound that's being made, or if there was any information that the physician wanted omitted, or any instructions to the pharmacist from the doctor, any labeling instructions. The most important part of the subscription is the dispense as written code, or whether the doctor specifies, does the doctor, is generic all right, or do you have to fill with the brand name? So in the subscription, one of the most important parts of it has to do with the doctor. That's where the doctor indicates whether or not you're allowed to use the generic. And then refill information is part of the subscription. What's a medication order? So what's the difference between a prescription and a medication order? Well, medication order is instructions given by a practitioner, specifies medications used for inpatient or resident. So in other words, you're in a hospital, the doctor's giving you a prescription. Instead of issuing something you're going to go have filled and take home, the doctor's giving you a prescription order. It's going to be noted in your chart, in your record, and then you're going to be given that medicine while you're in the hospital. So medication order primarily refers to the prescriptions that are ordered while you're in an institution. Typically related to the on-site pharmacy, which would be the pharmacy inside the hospital. They can be verbal, written, or electronic. The type of medication orders. So an admission order. Admission order, that's done when a person is admitted into the hospital. Sometimes you're going to have surgery, so you have time to go have lab work, and then you go meet with somebody and you go through this admissions process, and then you're admitted into the hospital. Other times you might have an emergency situation where you're rushed to the ER. From the ER, you're rushed to the ICU. No matter what, the admission order has to do with any of the drugs that you're taking prior to your admission. So when you're in the hospital, they need to know what drugs would this person normally be taking. taking outside the hospital. A suspected diagnosis, and keep in mind, a lot of times when somebody gets sent to the hospital, they're being referred from a doctor. They went to a doctor who says, oh, no, you need to go to the hospital. And a lot of times they're just making their best guess, like, I think it's appendicitis, or I think so. The diagnosis, any requests for laboratory values, instructions to go to the nursing staff, any dietary restrictions, and prescription orders. So this would include if a patient's being admitted, and we already know that they take 6 medications every day to manage their blood pressure. Well, those are going to automatically be placed in a medication order established to have those prepared, so each day they have the medications, unless the doctor orders otherwise. But admission order, that's just everything relevant that's input upon admission into the hospital. A daily order, there's 2 different definitions. One, some people call it a continuation order, but a daily order just means that it's a medication the doctor's prescribed, you're using it on a daily basis, and you're going to continue it. He's not discontinued it. Another reason why it's used is doctors round. They do rounds in the morning, very early morning. That's when they go see every single one of their patients. They review all the lab work. They see how the patient's responding, make any changes to the prescriptions the patient's going to be receiving. So that's when they would make any changes, and that's also called a daily order. What's important about the daily order is just to know that a daily order, it's medicines the patient's going to be taking throughout a day, and they're going to be taking it each day until it's discontinued. A single order, that just means a one-time thing. So if a doctor says, I just want to give him 1 shot of this drug, that's a one-time order, and it's entered one time, no longer repeated, discontinued. Stat order. Stat means what? Stat means now, immediately, quickly. It's an emergency order. It's called or sent electronically. It needs to be immediately input into the database and sent to the floor. A lot of the drugs that are used for stat orders, they're actually kept in automatic dispensing cabinets that are on the nursing floor. PRN, what's that stand for? As needed. So that's whenever a doctor writes for the patient to be able to have access to something if they need it, if they ask for it. So let's say that somebody's having mild pain, and so the doctor says, okay, they can have 1 extra strength Tylenol every 6 hours if needed for pain. Well, in the pharmacy, when you receive that, you see 1 every 6 hours as needed. We have to figure out how many is the most that they would need if they took this every time they needed it. So 1 every 6 hours as needed, well, that would be 4 a day. And in the hospital, you're going to find we fill trays with a 24-hour supply. So we would put 4 unit dose Tylenol in there. The patient might not take any, but if they do end up taking it at the maximum order, they could use 4 in that day. So that's why we send 4. But as needed order, that just means the drug's available. If the patient requests it, it will be made available, but it's also available based on the doctor's instructions. So like as needed every 6 hours. A standing order. I had a student put this once. If anybody puts this, you fail. But a person put a standing order is for a medication that can only be administered if a person is standing. No. Standing, that's an order that goes out to this, it's every single person that's admitted to the hospital with a similar condition. There's just a set of medications that goes in the tray. So for labor and delivery, if it's going to be a C-section, anybody with a C-section, we have 1 set tray that contains all these are all the medicines that every single one with a C-section is going to be receiving. That's a standing order. If it's a natural birth, we got a different set of instructions. If it's appendicitis, we got this. If it's so depending on the procedure, they already have a protocol. There's already they've gone through and made this list of all the different medicines that could possibly be needed. It's already prepackaged, put together, and it saves time. So standing order is just an order that's kind of prepackaged for people that are admitted with a similar treatment or for the same treatment. Discharge order, that's when you leave the hospital. So your medicines are going to have been changed while you're in the hospital. Even if you use an inhaler or insulin in the hospital, even if you only use it once, technically you're not allowed to take it with you, which is just a shame because they're so expensive. But the doctor's going to issue a prescription for everything you're going to be continuing to use at least until your follow up, and that's a discharge order. The discharge order can be filled. There's all hospitals have an outpatient pharmacy. An outpatient pharmacy is usually the last place you'd want to go because they don't typically deal with insurance. There's usually long waits, and they don't have the same, they don't keep as much inventory as community pharmacies. But hospitals do have outpatient, primarily like Ben Taub. They have an outpatient, but it's because their outpatient fills exclusively for people that have Gold Card, which is an insurance coverage that only applies to people that are going to Ben Taub. But otherwise, a discharge order, these are written prescriptions that somebody takes home and then brings to a pharmacy to have filled. Parts of a medication order. So in a hospital, you're going to have the date and time stamp, the standard ID for a patient. So when you are admitted to a hospital, there's something called an electronic healthcare record. So if you see down here, EHR. So there's just a couple of abbreviations that are critical. You're going to learn them, hear them over and over, and remember them. But an electronic healthcare record. So when you're admitted, they're very meticulous about all the information they're inputting. And when they Xerox your license and your insurance and any information they're receiving that's put into your file, but you're going to be issued a wristband, and that wristband is going to have a barcode. That barcode, when it's scanned, it opens up a database that's just your personal information, everything related to your care in that hospital. It's electronic. It's all electronically accessible. But and so the standard ID, that's usually the number you're issued as a patient in the hospital. Elements, you're going to have the name and dosage, routes of administration, frequency, and then the signature, which is usually digital. So you're going to find in hospitals, unless it's a very tiny hospital that's just so small and they can't justify the expense of the system I'm going to talk about. But hospitals, they're on something, there's a computerized prescription order entry. Everything's done electronically, and things are spontaneous. A doctor, he wants to order something for a patient. He punches a few buttons on his tablet, hits it, the pharmacy receives an alert. Pharmacy touches a few buttons, it's assembled, and then it's just sent to the floor to be dispensed. So this electronic health care record, what's amazing about it, there's a word called interoperability. Interoperability. Electronic healthcare records, what this does, this enables every healthcare member in the hospital team has access to a patient's information. So to appreciate this, as a pharmacist, there's many medications that when we're dispensing, we need to check blood levels, lab levels, electrolytes. We need to check prothrombin time. There's certain things we need to check measurements of certain drug levels. When was the last time this drug lab work was done? With the electronic healthcare record, we can easily access, go into, and we see every bit of the lab work that's been done. Anything diagnostic, ultrasound, sonography, x-rays, we can go see the diagnosis. We can see when the doctor last saw any changes in medications and discontinuation. We can go see the diet restrictions, what they're on. But on the other hand, the lab, they're able to go look into our records, look at our records, and to if they have any question about a patient. Let's say that there's a very extensive blood test to check for a peak and trough of aminoglycoside. Well, before they run it, they want to make sure the patient's still using the drug, so they could go check the record in the pharmacy and see that, yes, the doctor has continued it. Now, MAR stands for this. So these two, there's three actually that you're going to remember. EHR, electronic healthcare record. MAR, medication administration record. This is brilliant. This is just amazing. So when you're admitted to the hospital and they create your electronic healthcare record, you get a band, a wristband. That wristband has a barcode that's scanned. Then, whenever physicians make orders and send them through the computer, every drug, every prescription, we create a label. But we have a scan. So if a doctor orders a drug, guess what? In the pharmacy, you're going to scan the drug, and it better scan the same drug that the doctor ordered. So we're using this barcode technology. Then, whenever we scan the label we're putting on the drug, it better match what the doctor has typed in for the instructions of the ordering and the drug. Um, so this is barcoded technology whenever it's time for a patient to be given a dose of a medicine, either by mouth or an injection or to changing an IV bag. Anything that's given or administered to a patient, a nurse is going to scan, because the medication administration record, it's a part of the electronic healthcare record. So let's say that they're fixing to change your IV bag. Well, they have to scan your barcode on your wrist. Then they scan the barcode on the IV bag. When they scan it, it's not just checking that it's the right medicine for you. It's checking that it's the right time, dosing. It's even checking based on the NDC code of the pharmacy. So there's all these things that are in place to prevent mistakes from being made. But it's scanned and it confirms. So then the nurse makes the change with the bag. And then all of a sudden in your healthcare record, you have a permanent record of, yes, this patient received this medicine at this specific time. And so you have the most accurate. You just think about it. In the past, people would get busy, things would happen, but everything was in triplicates. And whenever you'd fill out paperwork and you administer something, you'd scribble your name and you just put it in a stack. And it might be up to somebody else a couple of days later to go through that stack and then be detailing in a patient's record and for billing insurance, and things that get overlooked and misplaced. This medication administration record, not only is it incredible for making sure, like, no, it's too early to do this, or but it's verifying the accuracy of things, but then it permanently records, and then it even serves as beneficial as far as all billing and repayment for insurance. All the hospitals that have these electronic systems, they have off-site backup. So off-site backup means they've got just like a giant computer system somewhere else that backs up every bit of information that's in that system, and they do it like every 2 minutes. And they do that just in case like a bolt of lightning hits the hospital and blows up the computer. Well, they've got a backup, someplace that's completely far away. These are just some medical abbreviations and acronyms. So NICU, ER, so that's the neonatal intensive care unit, ER, emergency labor and delivery. These are professional credentials. So RPH stands for registered pharmacist, FNP is the nurse practitioner. And then there's going to be, so we mentioned these because medical abbreviations and symbols and acronyms, they introduce potential for mistakes. So one person can write MI and see that it's a myocardial infarction, and somebody else might see it and not know what it means, just depending on your training. SIG codes, so SIG codes, they're here to stay. They're not ever going to go away. However, there's some that are officially listed on a do not use list. Now, there's an agency called the Joint Commission of Healthcare Accreditation, or they're most commonly known as the Joint Commission. If you're in a hospital, they have a list of do not use abbreviations, and their biggest one is just using the letter U for unit. So heparin is a blood thinner, it's dosed in units. Insulin is dosed in units. And the problem with a U is, depending on somebody's handwriting, it can be all sorts of things. It can be misinterpreted. So the Joint Commission, if you're a hospital to be accredited, you're not allowed to use U as an abbreviation. But it's not legal. there's nothing legal about it. It's just that, but they have accrediting authority, so that's where you're going to see it in the hospital. These are, most of our SIG codes are from Latin roots. They refer to dosing intervals, which is how often you take, and routes of administration. So y'all know all of these. And OU, HI, OD. So OD and AD. OD is right eye, AD right ear. D for dad is always right. And derecho. Medical abbreviations. So don't know how much exposure y'all had to this. It is a big deal. When I was in pharmacy school and we did not have the ability to just record lectures, or we didn't have the ability to take photographs of full black, well, we had chalkboards. We were having to take everything by hand, and we used just shortcuts, symbols, or abbreviations, any possible opportunity, just so we could keep up. And so these are the three most common, and you'll even see me use these. I use them a lot. But if you see a up arrow, that means increase. Down arrow means decrease. And then if you see the delta sign, a triangle, that means change. So increase, decrease, or change. But you can see how in somebody's handwriting, they could write it. If you're not familiar with it, you wouldn't have a clue what it meant. You wouldn't know. You might just see like that looks like a 1 or a what, you don't know. But and so these are discouraged, but just so that y'all are aware of symbols. And so the thing is, they can be easily misinterpreted if drawn by hand. And then you want to be cautious anytime you're interpreting pharmacy symbols. Computer generated are preferred over handwritten, but even at that, if you saw computer generated delta, you're not going to know that means change unless somebody specifically told you. So it's just those abbreviations and symbols. With the symbols, you only use them in an environment where people have been exposed to and are familiar with. Challenges of reading prescriptions. So the most common is poor penmanship. There's also spelling errors. Then we have look-alike, sound-alike drugs. So the look-alike, sound-alike, that was one reason that there was such a big issue with telephone errors. Just whenever somebody says something, people have accents. People are kind of distracted. Sometimes when on your end, there's a lot of noise going on, and no matter how many different methods you try, when you receive a prescription, you want to repeat it back and get confirmation that's what it is. And the best way to do that is by having them repeat or having them answer open-ended questions. But the reality is, you're going to find, just like when you're talking to customers, people will say yes, yeah, and not really even be listening to what you're saying or asking. But with the look-alike, sound-alike, it was over the phone when things were being verbally transmitted. But then guess what? Even when they're written down. So one of the most common look-alike, sound-alike drug combinations that was misfilled was the drug Celexa, which is Celexa, Celexa 20 milligram, and Celebrex 200 milligram. So Celexa is like Prozac. It's for depression. Celebrex is for arthritis, for pain and inflammation. That's Celexa 20 milligrams, Celebrex 200. And if people's handwriting isn't, it doesn't even have to just be horrible handwriting, but doctors, when they're writing fast or they don't complete what they're writing, it was real common for those two to be one to be filled in place of the other. Use of common but unofficial abbreviations. So there's a lot of abbreviations that are used in practice, but they're not standardized. So like, in other words, if you had a nursing text, a physician text, a pharmacy text, and you looked, they all three wouldn't have the same abbreviation. In pharmacy, like we'll write out ETOH, that means ethyl alcohol, but no alcohol. Physicians use this, but nurses don't. And so we got to keep in mind we're all different healthcare professionals working together. And so we want to try to use abbreviations that are accepted by all of us. Using a brand name drug when the brand name is not even manufactured. So what has happened is there's a lot of brand name drugs that were so expensive. The generic came out. Nobody's prescribing the brand. The brand name company realizes this. They just discontinue manufacturing it. But the doctors learned and continue to learn. So even when we're in school, we're learning the antibiotic Augmentin. Augmentin has not existed for 20 years. We have generic. So whenever I say Augmentin, you're going to know I mean generic Augmentin. Now, what happens though is if a doctor writes for a brand name intending on a generic, but it's somebody who's new to practice or unfamiliar, you're going to be doing your very best to try to identify or find this drug. You'll type it and something might pop up in the computer that looks close. And so anyhow, it's just very, very common. Doctors in medical school, pharmacists, nurses, we all learn things by a brand name first. And then the issue's been that we have all these brand names that are no longer made. Then there's abbreviations that are easily confused with other abbreviations. So and that's the one, it can be very, very dangerous just when it's written in handwriting. CC, I don't know if anybody uses that, but a CC, 1 cc is the same as 1 ml. So a cubic centimeter is a milliliter. But CC, you can see how that could easily be misconstrued. Okay, this is the electronic system. Computerized provider order entry systems. They're also, though, called computerized prescription order entry systems. So it all depends on who's doing the training. If it's nursing or doctors, they'll say computerized provider. But in pharmacy, it's computerized prescription order entry system. What's important for you to know is that it's software that allows the doctors or prescribers to enter prescription orders in an inpatient setting, and they do it it's usually they have a tablet. The CPOE is accessed through computers and other mobile devices. They even have application for the iPhone. It interfaces with that EHR. I mentioned the EHR is this electronic health record for each patient. Advantages of CPOE. One of the things is when the doctor is entering an order for a patient, if the patient's allergic to the drug, if there's a contraindication, like let's say that it's a pregnant female and he's typing an ACE inhibitor, before he can even hit enter, it's going to alert, no pregnancy contraindication. Or if he's placing an order and it's a higher than typical or customary dose, it will alert. So just like this computer, it's already catching potential problems before it is a problem. It eliminates poor handwriting, decreases spelling errors. So it does have the spell check. It also has where you first start typing a few letters and it finishes. It restricts non-standard abbreviations. One thing, you have immediate access to a patient's medical records. So just a decade or two ago, if a doctor's writing something for a patient or has any questions, they'd have to pull the chart and go hunting around and looking and hoping all the most recent current paperwork is in there. Now they can see immediately whatever results have been reported or available from the lab. They can see everything that's been done by the pharmacy. They can see the MAR, the last dose of everything administered. You have improved documentation. So this is record keeping. And so you can understand in the past, the more you deal with humans and activities, the big thing was that you would have these triplicates and they would go to different places. Whenever work was completed, they'd be initialed, signed, put in the stacks, and then sent to another place where somebody else would go do data entry into a patient's file. And so there was just all kinds of errors and problems. Now, though, when things are done, it's entered, it's electronic in the computer system, and it's interoperable. So pharmacy sees the lab, sees the doctor, and it's also perfect for billing purposes for insurance. It enhances coordination of care. So coordination of care, that's just everybody working together to provide the best care to the patient. And then finally, it identifies any non-formulary drugs and provides the equivalent. So let's say, for example, I'm in the hospital and the doctor's typing in prescription and he's having Captopril 50 milligram guess what? Alert. It's going to give them alert and pull up a screen and say captopril non-formulary. Then it's going to say lisinopril 20 milligram is equivalent formulary product. So he just pushes one button and one button. He's changed it to the ACE inhibitor that is a formulary drug that's the identical equivalent of what he was going to go prescribe. So he doesn't have to go look up anything. He doesn't have to think. And it improves accuracy and it improves even compliance with the formulary. Disadvantages, its main disadvantage is that it's expensive. It also takes time to install. So it's the hospitals that are little hospitals that are remote, like a 20-bed hospital, and they only have maybe 5 or 10 people in the hospital on a regular basis. They just can't afford the technology and the equipment because it's expensive to buy the software. You even have to have ongoing support, computer support, so you pay for maintenance and IT for troubleshooting and support. It also requires training, so anybody using the system has to be taught. So anybody that's going to be using the system, that's everybody in the hospital, that's going to cost money, take time, and then there's still going to be some human error. Prescription labels. So what's the role of the healthcare provider? Only the pharmacist can perform the DUR. DUR is the drug utilization review. Oh my God, guys, you know what? I'm so sorry. Look, why didn't somebody say something? Hold on, people. Okay, I'm going to end here. I am so sorry. You're going to get out early tomorrow. Tomorrow morning, we're going to pick up here, and tomorrow morning, I'm going to help you see. So y'all don't really need to worry about printing out those prescriptions, or you can do it in advance. I'm going to quit recording real quick. I'll just show you, but what I am going to do is make sure